Hello and welcome to my CHIP final presentation. My name is Alex Nelson. To begin, I'd like to provide a quick synopsis of my host site this summer. As a 501c3 nonprofit organization officially recognized in 2018, our primary focus is to fundraise to offset the costs of mental health services for the uninsured and underinsured. These include psychiatric services like counseling and therapy, psychological assessments for various pathologies, resource coordination and allocation, and various assistance request opportunities tailored to the patient's needs. Adjunct to that, we aim to provide an accessible collection of mental health resources and assistance request opportunities for those in need throughout the St. Croix Valley region. This is all an effort to provide individuals and families with the most relevant, comprehensive toolkit to navigate the thralls of mental illness, access appropriate care, and rediscover a life worth living, even when it may seem lost indefinitely. We achieve this by disseminating destigmatizing awareness, promoting communal didactics, guiding and informing actionable prevention strategies, and prioritizing a grassroots perspective through our community interactions. When I say a simple archetype, I mean quite literally that, an explicit representation of what motivates us. We have tangibility and we are growing. These figures are increasing faster than they ever have in our 3 short years, and we seek to continue to exponentiate that. Witnessing tenacity firsthand, guiding our neighbors to healthier tomorrows, and watching our community thrive seem like abstractions until we consult our metrics. 204 therapy sessions covered, over 20,000 donated to offset these costs, and over 70 community members assisted. However, this is just the beginning. Of the 266,000 adults in Wisconsin who did not receive the needed mental health care, 37.3% did not because of cost. Of the state's 5.85 million residents, 5.8% are also uninsured. There is a remarkable need, one we have experienced firsthand, and we are just beginning to contend with it. Now, what does this look like in action? While originating around assistance request opportunities, our reach stems far beyond to promote true prophylaxis. We work alongside our community partners to properly assess and respond to all corners of need. Early intervention is paradigmatic, and there are several arms which we extend forth. Part and parcel to financial support, educational outreach opportunities provide a window to the source, allowing us to combat the stigma and promote awareness utilizing a grassroots approach. From hosting prominent community members to speak on neurodiversity, to working with 211 of the United Way of St. Croix Valley to schedule mental health first aid trainings, we see educational programming as paramount to fundamental change. Second to that are events. Aside from fun distractions from the workday, we see them as a catalyst fostering deeper levels of mutual respect, empathy, and compassion for our constituents. From gift of gratitude, support huts in schools, and support community campaigns, to charity events such as golf tournaments, we aim to nurture a mutual comfort level for those individually impacted by crisis and trauma. Lastly, and most relevant to my role, is research. When I mentioned rubber meeting road, this is quite literally where it happens. Research serves as the interface between postulate and praxis, the modus operandi of any institution looking to serve the common good. Our research is our justification, and I want to devote the rest of our time together to its discussion. To provide some needed background, it is imperative we understand that suicide mortality lacks specificity. Often resulting from an untreated underlying mental health condition, suicide can affect anyone regardless of age, gender, or demographic, sending shockwaves through families and communities. One suicide death has the possibility of impacting 135 lives around it. And overall, the rate of suicide has increased by 35% since 1999. With 78% of decedents being male and 46% having a diagnosed mental health condition. In 2017, suicide was the second leading cause of death for American Indian Alaskan Natives aged 10 through 34, African Americans aged 15 through 24, Asian Americans aged 15 through 24, and Hispanic people aged 15 to 34. Suicide rates in the US have increased from 1999 to 2016, seen in both infographics, with the greatest increases in rural counties. Access to firearms and a higher proportion of uninsured residents was associated with an increased incidence of suicide mortality. Similarly, higher social capital, such as increased interpersonal networks, were associated with decrease in incidence. Simply put, suicide is much more than a mental health concern. Homing in on our local community, of the 47,511 American suicide decedents in 2019, 845 were Wisconsinites. Of those 845, the majority were male between 2013 and 2017, whereas the majority of those hospitalized or presenting at the emergency department with self-harm injuries were female between 2016 and 2017. The suicide rate among Wisconsin residents has increased by 40% between 2000 and 2017, with the highest rates among individuals ages 45 through 54 and in rural counties between 2013 and 2017. Firearms were the most common method of suicide, with 71% of statewide firearm deaths related to suicide. Almost 1 in 5 suicide decedents were veterans, with 97% of veteran suicide decedents being male and 70% utilizing a firearm. 271 adolescents ages 10 through 19 died by suicide between 2013 and 2017, and LGBT youth are 3 times more likely than their heterosexual peers to have suffered from suicidal ideations. In Wisconsin between 2013 and 2017, the most commonly reported circumstances among suicide deaths were feeling depressed, having a mental health issue, and having a history of treatment for mental health or substance use issues, with depression being the most common psychopathology among suicide decedents. Of the Wisconsin suicide deaths between 2013 and 2017, 1 in every 5 either had a job or financial problem at the time of death. As of 2018, we know that 14.8% of Pierce County and 9.4% of St. Croix County adults report having insufficient social and emotional support. In both Pierce and St. Croix counties, over the past 30 days, adult residents experience on average between 3 and 4 poor mental health days. Furthermore, the population to mental health provider ratio in Pierce County is 2,430 to 1, compared to 910 to 1 in St. Croix County. While not tremendous, the regional disparities persist nonetheless in resource availability and allocation relative to local need and presenting risk factors. This is where our work comes in, coordinating care analogous to our mission. Predicated on prior studies understanding the spatial risk patterns of select mental health phenomena, our research distills a similar objective: to identify and exemplify spatial distribution patterns and their magnitudes underpinning regional suicidality using select screening measures. We aim to not only guide early clinical and public health intervention strategies with higher specificity, but to also provide metrics of scope and magnitude for community health awareness promotion. As a co-PI, I will be orchestrating this cross-sectional survey design with the help of a colleague, Dr. Phil Galley at UWRF. Currently, I am assembling a formal study proposal to be submitted for approval by UWRF's IRB, and ideally, I aim to begin data collection this fall in hopes of preliminarily contributing to Healthier Together's upcoming CHNA end of year. There are well-documented gaps in care that suicidal individuals often fall through, and there exist evidence-based solutions to seal these gaps. Namely, gaps in proactive screening measures for identifying patterns of suicide risk motivate this research. And while not the primary responsibility of clinicians in both inpatient and outpatient settings, as well as public health officials informed by such research, there are several steps we can take as a community to dismantle the notion of inevitability. Increased substance use, aggression and impulsivity, social withdrawal, and dramatic mood swings are evidence-based warnings preluding more serious behaviors. Before we part ways, take Be the One To's 5 action steps with you. First, ask. Speak non-judgmentally and listen actively to ideations. Remove your opinions from the situation and never promise secrecy. Then, be there. A physical or emotional presence shows full commitment and limits isolation. Simply sit and listen actively. Next, keep them safe. Utilizing lifelines and authorities as necessary, safety ensures lethal means security. Then help them connect. Help them establish a safety net of contacts and a safety plan to guide them through a crisis. Finally, follow up. Reach out to see how they're doing and if there's anything else that they need. Suicide is preventable, and responding to risk is not only feasible, it is necessary, even for those without specialized mental health training. Simply put, suicide is so much more than a mental health concern. Thank you. Here are my references, and I also want to give a special thank you to Anna and Nikki for making this happen. This was a truly amazing experience, and I am forever grateful.